Today, I am honoured to welcome Professor Bassel Wattar to the podcast. Professor Wattar is an experienced gynecologist with over 10 years of service in the NHS. He is an accredited RCOG specialist in reproductive medicine and surgery with an advanced expertise in fertility treatments such as IVF, IUI and donor-assisted concept, as well as managing male infertility and complex ovulatory disorders. As a certified BMS menopause specialist, Professor Wattar has a special interest in addressing challenging menopause cases, including those related to cancer, premature ovarian insufficiency, and premenstrual syndrome. He is also an associate professor of reproductive medicine with research focused on cutting-edge treatments for fertility, PCOS, fibroids, and menopause, and has published over 80 peer-reviewed articles and book chapters. Through his work, Professor Wattar is dedicated to promoting women's health, raising awareness, and delivering holistic, patient-centered care. It is an absolute privilege to have you here, Doctor. Welcome to the Understanding Your Body Through Your Mind podcast. Thank you for coming.
Thank you for having me, and really appreciate the opportunity to be with you today and talk about, this important health condition and raising awareness about women's health, a topic very dear to my heart.
Oh, amazing. And we are so grateful that you're here to talk about something that affects not just women, but also men, because I think it's imperative and important that everybody knows how their sisters, mothers, daughters, wives function. So this is important. So I'm not well versed in the subject, so I'm learning just as everybody else is learning. So I'm going to be very inquisitive and throw you as many questions as I can. I know our time is limited, so I'm going to go straight in. So one of the things that I was really shocked to discover is that around 66% of women in the UK will develop at least one urinary fibroid during their lifetime.
Yeah.
I mean, that is a big number. So I guess the first question is, what are fibroids and why do they develop?
Fantastic sort of introductory question. So it is a very prevalent health condition, and as you mentioned, it often goes undiagnosed, and that is because in the large number of cases it's asymptomatic. So women will not know or notice that they have a fibroid. Sometimes it's an incidental finding when they have an ultrasound scan for whatever reason that this fibroid is picked up, but often it's dismissed and there's no intervention done for it. For fibroids are basically benign tumors, so there are cells who proliferate and they go into haywire fibrosis, and they cause these masses that go inside the womb. Now, the good news is that while they are tumors, they're benign, they're not cancer, so there is no risk from that angle, but that doesn't mean that they could have a significant adverse impact on the woman's health in general. And actually, some recent sort of qualitative research is suggesting that the impact of fibroid on women who are affected with severe symptoms is equivalent to having breast cancer or diabetes or cardiovascular disease. But unfortunately, because of the annotation of being a benign tumor, it's often downplayed and no sort of acuteness is linked to offering proper diagnosis and proper timely management. And that sort of compiles and adds into reducing the quality of life of women who are suffering from these fibroids, because they often go for a long period of time before they actually get someone who properly diagnose them, listen to their concerns, and offer the right treatment for them. So in a nutshell, it's a very prevalent health condition locally. It's not malignant, but it can have significant adverse impact on someone's quality of life.
So you said something about it going undiagnosed and it being asymptomatic. I remember when I went to get a checkup and I got a scan, and the sonographer was like, "Oh, you've got 2 little fibroids there. Oh, it's fine though. They're under 2 centimeters. They're very tiny." And I was like, "Oh, what do you mean? Like, what do you mean I have 2 fibroids? How do we treat this?" And she was like, no, nothing. You don't do anything. So I didn't have any symptoms. But for those who could have symptoms, what are some of the common symptoms that people women might have with fibroids, and how is it diagnosed?
Sure. So the symptoms that emerge on the back of fibroids is not just linked to the size of a fibroid. It's rather linked to the size, location within the womb, and number of these fibroids. Now, clearly, the bigger the fibroid, the closer it is to the uterine cavity, and the highest number or the higher number of fibroids, the more symptoms are severe. The traditional first sort of most complained about symptom is heavy periods. And we're currently doing a big research project funded by the NIHR on what are the available treatments for heavy periods. And we've been speaking to a lot of women, understanding, how do you diagnose heavy periods? Because for one woman, this is something very normal and she's been living with throughout her life, and she's changing 5 pads a day and it's normal. Yeah. For others, they change 2 pads and they consider themselves to have a heavier period. So there is a subjective element to it. And unfortunately, somehow neglecting this health area is forcing a lot of women to normalize the symptom of heavy periods. So they just go and say, that's just my period, how it is, and I just carry on. And obviously that brings on a lot of additional sort of health and societal issues, days missed of work, days missed of study, chronic anemia, iron deficiency, fatigue, and all these sort of compounding adverse effects that are often not spoken about and not researched very well. So fibroids is one of the key reasons someone would have heavy periods. This is particularly when the fibroids can be in several places within the womb. They could be on the outer edge of the womb, they could be within the muscle of the womb, or they can be just under the lining of the womb that generates a period, and also where a baby will be implanting. So a fibroid that is closer to the lining of the womb is usually more problematic, particularly if it's bigger, because it's contributing to heavier periods and can potentially contribute to infertility or subfertility. So these are the two commonest sort of symptoms. Other symptoms that come with the pressure volume. So as I said, the bigger the fibroid, the more fibroids number, the more pressure and heaviness symptoms. So a lot of women might, I've operated on some ladies who had almost a 20 weeks pregnancy size uterus with just fibroids. Wow. So a huge pressure and huge symptom. And that can often manifest with, for example, pressure, heaviness, increased urinary. So the frequency, they have to go to the toilet multiple times because these fibroids are pressing on their bladder, and other sort of associated symptoms. So these are the 3 cardinal symptoms: heavy periods, maybe sometimes contribution to infertility, and pressure and heaviness symptoms.
Wow. So, gosh, I when you explain things in the matter which you have explained, leads me to ask the question, why are health professionals so submissive in this condition? Because it's not, gosh, when doctors, diagnose you with having fibroids, they can be kind of like throw you away. Oh, no, it's fine. It's okay. You've only got 2, if you get more, then we'll look at it. And oftentimes you do go on to develop more. As I said to you, I then went back for another scan 4 years later, and there was another one there. And I'm like, okay, guys, what are we going to do about this? And they were like, well, nothing. You didn't have to do anything. So why are we so dismissive and not treat it at the early cause when it can lead to it being what you've just described?
Sure. I think multiple factors. Number one, generally speaking, dare I say, there is, I think, an underappreciation or lack of awareness among health professionals around common women's health conditions. So some of the commonest conditions that get mistreated is endometriosis, polycystic ovary syndrome, and certainly fibroids, because in all fairness, I think most of GPs in the UK are hardworking professionals that they want to give the best to their patients, but we might be not educating GPs enough about particular women's health issues. And the other thing is, women's health is not a small discipline or small subject. It's actually quite nuanced, and it's quite a big discipline of a medical specialty. And nowadays we have subspecialties. So not every obstetrician will be able to operate and diagnose uterine fibroids. It takes a special training. So I think it's more about rapidly diagnosing fibroids and then helping the patients to seek the advice from the right professional, from the right specialist gynecologist who has the skills and expertise to advise them about their fibroids. That's number one, so lack of awareness and education. Number two, I think, is this annotation that I mentioned at the start, is that they are benign. So as I said, there is lack of acuteness about, oh, it's fine, it's a fibroid, it's benign, it will not do anything for you, we don't need to treat it. In contrast to a cancer where everyone is so alarmed and there is a set time limits to treating it and diagnosing it and so on. And that often puts a woman with uterine fibroids in second sort of stage in terms of need to access health resources that are limited, unfortunately, in the NHS, and we hope this will improve. So these two combining factors. And the other thing is that, as I said, is normalization. For example, a lot of the patients I care for, particularly those of Black ethnicities, they have fibroids in their family and they say, oh, well, my mom had a fibroid and she was okay. So they normalize it and they don't think it's an important thing to go and advocate and ask to speak with the right health professional that will help them. So, it's a compounding issues with multifactorial sort of causes. And personally, I think advocacy and disseminating proper education like you guys are doing is key to resolving that.
Which brings me to my next question. You mentioned ethnicity there. So how much of a role does genetics play in this, and race, and also lifestyle in fibroids? Because I know that there is potentiality for women of certain ethnic minorities to have fibroids in comparison to their white counterparts. Is there research in that? Is there data as to why this is?
It's genetic predisposition, and you're very right, as in fibroids tend to be more prevalent in women of Black and Afro-Caribbean ethnicity and more Asians, but that doesn't mean that women of Caucasian ethnicity don't have them. It's equally prevalent among them as well. There's certain lifestyle factors, for example, the number of children you would have, because obviously when someone is pregnant and they're given a baby, the womb will reshape, and sometimes if they have a small fibroid, it undergoes something called red degeneration in pregnancy, so it changes its shape. If someone has been, for example, on the mini pill for a long time, it might sometimes suppress the growth of a small fibroid. There's quite a few variables that plays into that. Something that is frustrating is that majority of research in this discipline tends to come from Northern America and Europe. And we see very little research coming from Africa. I think there is need for a bit more infrastructure and a bit more awareness about the need of that. And that is important because, women's health matter everywhere, not just in Europe. So we need more collaboration, and we need more data that comes from different parts of the world. But at least in the research, particularly coming from the US, where there's big African American population, there is very strong data to suggest that there's higher prevalence of uterine fibroids among women of this ethnicity.
And then what would you say the effects of fibroids on fertility and pregnancy are?
Fantastic question. As a fertility specialist, I get that often. The honest answer is that we do not have a clear causality cause, as in we don't have a clear, as in if we say 1 + 1 = 2. So there's no clear pathway when we say there is a fibroid, therefore there is infertility. However, there is an association between having a fibroid that is submucosal, where I mentioned that is closer to the lining of the womb, and perhaps delayed infertility or recurrent pregnancy loss or higher miscarriage number and so on. But this is just an association. So there is some trials where they looked into, do we remove a fibroid if someone, for example, having recurrent pregnancy loss, or they have an infertility, whether that it will improve fertility afterwards? And the answer is still unclear. These trials were small. So there's no strong guidance. If someone having some fertility and they have a big fibroid, do we actually remove it to improve their fertility? So far, the consensus seems to be it depends on their location and depends whether they're impacting the uterine cavity or not. And when we are hoping to optimize fertility, what we want to see is that the inside of the womb is regular, even if there is a fibroid within the muscle of the womb, but it's not breaching into the cavity of the womb, we seem to think that there is less impact on fertility. So some of the key tests that we would do as fertility specialists, unlike, say, in the community, is something called saline infusion ultrasound scan. And I recommend having this done before any surgery or taking a decision about that. And what we would do is that we will infuse a little bit of water inside the cavity of the womb and take an image with the ultrasound so that we can see if a fibroid is actually indenting. I'm getting getting a bit technical, but
Oh no, we love this.
Yeah,
So I'm like, whoa.
because this is very important. I see a lot of patients who get exposed to completely unnecessary fibroid surgery that then cause complications such as adhesions inside the lining of the womb that makes their infertility case worse. So it's very, very important to get the right assessment and really have a frank discussion with the patient. Would you really benefit from removing this fibroid versus potential risks? And this will only happen when you do the right test and speak with the right fertility specialist.
Wow, that's fascinating. Thank you so much for sharing. And then I guess it leads me to the next question, which will be, what are the potential complications or implications if it goes untreated?
As I mentioned, the usual presentation of fibroid is of chronic nature. So there is nothing acute that happens. It subtly has an adverse increase in impact on a woman's quality of life. And that's what I mean is that this nature, the chronicity of it, leads to delayed intervention and delayed action. And like I see some women who have big fibroids and they're having heavy periods every month and then doing nothing, and they come to us to the hospital with a iron level of like 70 or 80. So it's quite low. Yeah. And they have chronic anemia. They're often fatigued. They're often very, very tired at work, and they feel they can't cope. And it's just because there's this continuous chronic bleed and loss of iron stores that contribute to their, adverse health. And that unfortunately delay taking action. And so this is one of the commonest things that needs to be treated. The other thing is that sometimes when it's ignored, the fibroid or the fibroids will become much bigger. That then complicates doing any further future surgery. So instead of having something that is minor potentially to remove a small 5 centimeter fibroid, for example, if it needs to be removed, then suddenly doing surgery for, a 20-week gestation fibroid becomes very complex. And then that surgery becomes higher risk for complication. So it needs to have the right balance. And a very important element is surveillance. As in, like, if someone like in your shoes, for example, were found to have an incidental finding of fibroids that are small and they're not causing the symptoms, it doesn't mean we ignore it. We don't do anything about it. It might be that you just have an ultrasound scan every 2 years just to see how they are, or you just adopt certain lifestyle intervention, or have, I'm speaking out of my head, but you have a Mirena coil that might help with the symptoms and so on.
Okay, so Doc, can you break down what a Mirena coil is, because I'm not.
Yeah, so a Mirena coil is a very effective treatment form for heavy periods. It's actually an intrauterine device that is primarily used for contraception.
Okay.
It's a very reliable device for contraception, but it also releases a small amount of the hormone inside the womb that suppresses the periods. But we found that it might be also suppressing the growth of the fibroid, although this is a secondary benefit. Mm-hmm. And so the beauty about it is that it goes into the womb, and then it's licensed for use for up to 5 to 6 years for heavy periods. And then you don't need to take a pill every day. If you're someone who's active, who, for example, wants reliable contraception, it might be a very, very convenient option for someone who doesn't want to take immediate action, just want temporary symptom control. It's a very good and convenient option. Unfortunately, it has a negative connotation on the internet. I think it's those who have bad experience with it who speaks more rather than when someone has good experience, you don't bother going online to speak about it. But statistically, it's from research wise, it's a very good and convenient treatment for the many, but not for everyone.
So I'm one of those people that tends to be quite holistic about most things. So before I get medical intervention, I kind of research the subject and I go, can I cure this with some sort of herb or seed, or by working out, drinking more water? So do you think that it's something that's curable through lifestyle choices? Is there anything that you can do and change in your lifestyle that can maybe shrink the fibroids? Or is this one of those things where it's actually, no, it's just surgery?
No, very good question. It's not surgery. So let's go by the mechanistic pathway. I'm talking, again, a bit too nerdy. But
and we absolutely love it. More of that.
Fibroids are benign tumors that feed off a woman's hormone. So they feed off the cyclicity of having a period every month. And the higher the estrogen is in the body, the fibroids will grow. We know that they grow very subtly. So they grow about 0.5 centimeter per year. They don't grow very quickly.
Okay.
So if you want to suppress their growth, the natural sort of next step is you stop the hormones. So you give a treatment, a contraceptive option, for example, that will suppress the periods. Or there are more nuanced treatments that are emerging now. So it's an exciting time because we're seeing more and more treatments available for women with fibroids, but it could be very confusing for a patient because we now have like about 9 or 10 different treatments that are available. So you can start by hormonal treatments that will stop the hormones and stop this feeding of the hormone, or you can have a bit more targeted treatments that are, we call them hormone receptor modulator treatments, that they have some impact in shrinking the fibroids a little bit. And then you can step up, I don't know if I'm jumping the ship or I'm talking about the treatments, and then you can step up into treatments that are designed to directly shrink the feeding vessels into the fibroid or the fibroid mass itself. So for example, there's an embolization of the feeding vessels to the fibroids with interventional radiology. There is new treatments just in the last 5 years that are about sonication. It means we put a very high frequency ultrasound beam to the fibroid, and that will liquefy it, or with a needle with like some energy to liquefy the inside of the fibroids. And then finally, there is excisional surgery where you're basically taking it out. The difference is that the only way to actually get rid of them is surgery. If you really want them out, pretty much all other treatments is managing the growth and managing the symptoms associated with fibroids to avoid having excisional surgery. And this is critical, particularly for, say, someone who wants to maintain their womb because they have more babies. Then they don't want to do surgery to risk having their womb being taken out, for example. So as I'm saying, the conversation is nuanced. And unfortunately, like you mentioned, a patient will often go and ask Dr. Google. I think we lack is a fibroid charity or a patient advocacy group that will share reliable patient information, leaflets or information that are trustworthy, produced based on research and clinical advice, and they're in easy language that the patient can digest, and then help them make an informed decision with the help of their health professional.
We were talking about this just before we started. Why do you think there is such little research? And this is me going off topic a little bit, but again, I'm very passionate about this. Such little research in women's health and things that affect women's health. It's not at the same level that there is of men's health. And oftentimes, when research is being done on subjects that impact women, it's a very small scale. Why is that? Why do you think even now?
Again, as a researcher who often bids for funding for women's health research, this is an important thing. But to clarify, I don't think there is a concept that's called men's health. It doesn't exist.
No.
So it's good that there is a concept of women's health, because men's health gets diluted into urology or other elements. So there is no such thing as men's health per se. But you're very right that women's health tend to receive less funding compared to cancer, compared to cardiovascular health, compared to, for example, primary care and other more prevalent disciplines. And I think that has to do with the perceived acuteness and severity of these disciplines, as in we all want to beat cancer, which is an important cause. We all want to beat stroke, for example. So these are big diseases that attract a lot of research funding. The sad reality is within women's health, traditionally, pregnancy tended to take a lot more funding. So when say the government is saying, okay, there is £1 million or 2 or 3 for women's health, majority of that funding went to say, how can we stop stillbirth? How can we stop preterm labor? Which are very important health conditions. I'm not dismissing them.
Yeah.
But that left women with fibroid, with PCOS, with endometriosis, with very little, if any, research at all that is being funded. So it's very good news that we have this recent government women's health initiative, which has taken a very radical approach to realigning and acknowledging all of women's health need across their life course. So big advocate of women's health is a life course perspective.
Yeah.
And women's health is predictable, as in every woman will need some contraceptive need, will need some care in pregnancy, will need some sort of fertility treatment, and will need some menopause treatment.
Yeah.
And if you scope it in that perspective, you can really align resources in a way that is equitable, and it will help women in their life course to get the right research and the right care that is evidence-based at different stages of life.
Wow. Well, I hope that I'm happy that the government has this initiative, and I hope that in 5 years' time, we're in a completely different place than we are now, because there's so many things that are still uncovered, like the PMDD that I hope you're going to come and talk to us about eventually.
With pleasure.
So then my next question is, I know that having fibroids can be quite painful when it comes to intercourse, which can then lead to self-esteem issues and mental health issues. If you are somebody who has fibroids and isn't getting any treatment for it, and you're suffering from painful intercourse, what can you do to avoid it? Is there anything that you can do to avoid it?
I'm not sure, but you can avoid it, but you can get proper care and proper help. So first of all, speak with your partner about it.
Right.
I think we have to involve the men in this discourse, and don't try to shy it or hide it. Like, for example, some of my patients that I care for, they have a big mass, so they have like a pedunculating tummy.
Yeah.
And it's not because they're gaining weight, it's actually the fibroid just prolapsing. They have body image issues.
Yeah.
And it's not their fault. And it's curable with surgery, for example, but it might be that there's some preparation to come to it. So I think, first of all, is, speak frankly with your partner about it, and get them engaged in this process. Secondly, speak with your GP. And if your GP is not listening, change your GP. It's like, I get frustrated. Some of my patients come to the clinic and they say, oh, my GP is not listening to me. It's like, well, change your GP. Just take action about it.
Yeah.
Secondly, I think, luckily, we're starting to have more fibroid advocacy groups that are available. So I give a shout out to the Guidance Suite, by Dawn Heels, that she does great work in fibroid advocacy. She was a fibroid patient herself, and I often, help with their patient support groups, and there is help online. So just join a peer review group, because sometimes you can often speak some things with your doctor, but some things you need to speak with others who are in the same boat, and they will give you slightly different type of advice based on lived experience, and it's equally valuable. And then finally, I think I tell all my patients, knowledge is power. So the more you know about your health condition, the more information you get about the type of this fibroid, its location, its impact on you, what are the potential treatment options, the more you are closer to return to good health and get rid of that adverse impact.
Okay, so Doc, I know you've already mentioned that there are some support groups out there for women who are suffering from fibroids and need help and assistance. I would like you to share any other support that there is available just before we go into breaking down the science, which is the stuff that I really, really enjoy.
Yeah, certainly. There is the British Fibroid Foundation. I think it's an established charity that offers a lot of reliable resources. One of the key charities that we work closely with is the Wellbeing of Women. And so they are one of the oldest charities looking after, women's health in general. And they do dedicate a lot of resources to women with heavy periods, particularly those with fibroid and other conditions. So these are some of the top resources, and I'm sure we can share some in the show notes and in terms of how people can access them.
Absolutely. Brilliant. And then, so looking ahead, what advances in research or treatment for fibroids are in the horizon?
A lot of very exciting stuff. So thank you for mentioning this. So I think, firstly, we now have some newer agents that are, as I mentioned, that are hormone receptor modulators. And then what they do is basically they block certain receptors on these fibroids, and therefore the fibroids no longer gets these hormonal messages, and they slightly shrink with time. There were a period with slight safety concerns around these pills, but they're back on the market, and they can be of certain help for certain population of patients. For example, we don't have long-term safety data for them, so we can't use them for more than 2 or 3 years. There's also newer agents that are coming I'm gonna mention the name, is a bit sciencey, but
Oh,
I
we
think
love the science stuff. So
it's
mention all the names.
they are GnRH antagonists, and
Yeah.
they're blocking the hormones or the signals from the brain to the ovary altogether. And so again, like we spoke, that this is have a secondary effect on the fibroid. So they're suppressing the periods and they're shrinking the fibroids further. There've been quite a few good quality randomized trials around these newer agents, and so far they're showing very promising results, and they are starting to become more available in the NHS. We made a big bid in my NHS space in Epsom St Helier, and now we offer them on the NHS to all of our patients, and we're hearing a lot of good feedback, and I hope they'll become available in all NHS spaces very soon. We're seeing more and newer types of coils. They're very similar to Mirena, but at least there is options, and I think they're a bit cheaper, which is promising for the NHS. Now, the exciting elements that are also emerging is that there is more minimally invasive treatments happening for fibroids. So as I mentioned, what we call HIFU, high frequency ultrasound sonication. Very famously, Condoleezza Rice, the former foreign secretary of the US, she had that treatment. So there is more experience emerging with it. The machines are becoming smaller, they're becoming easier to use and more accurate. It's not still wide in mainstream treatment available. It's available in niche areas, but it's promising. It's a new technology that we should push forward, and it might be, minimally invasive. Nowadays, we're starting to see more role for radio frequency ablation. And this is, again, an emerging treatment where we pass a small electrode inside the fibroid under ultrasound guidance, and then we release some energy waves so that will liquefy the fibroid from the inside out. And again, it's a new thing. It's relatively new. It is available in some NHS units, very few, like 2 or 3 in the whole country. It's happening. It's progressing. I think there will be a period where, until there is more safety data coming for it, there's more experience in offering it, and I think this is very exciting. It's something that we are proactively researching. And I think a critical thing that has happened recently is the mainstream use of keyhole surgery to remove fibroids. So traditionally, fibroids were removed only through open surgery, like a C-section or even what we call a midline laparotomy, which is quite a big procedure. And nowadays, there are quite a few well-trained gynecologists across the NHS for the whole country that are offering keyhole. So again, in my NHS space, we offer keyhole surgery to most women who have this condition to a certain limit, obviously. And the advantage is clearly you have very tiny, small hole on your tummy, and the recovery time is very fast and not debilitating, with no nasty scars on the abdomen. So this is promising, and this skill and the technology is becoming more and more available. And again, we have more expertise now in what we call, again, a very long name, but transcervical resection of the fibroids, which basically means we go through this neck of the womb with a scope. We see where the fibroid is coming inside the cavity, and we cut it out. And this is minimally invasive, no cuts at all on the tummy. We go through the neck of the womb, basically. And this is a very well-established treatment, and I think it's available in most NHS spaces. So as I mentioned, it's exciting time. There's more and more treatments. The hidden barrier is that we often see patients for a maximum of 20 minutes consultation in the clinic. So digesting all these treatments and telling, telling the patient on the pros and cons of each of them is a challenge. So I think we need more research to tell us which treatment is best across what patient group, because not everyone is equal. I'm a strong believer in, individualized treatment management. You can't just pick a treatment off the shelf and say
personalized care.
One pill fits all. So, and we need more research to tell us which work best in the NHS. The NHS is a very particular publicly funded health resource. Is different than the US, where it's insurance based and you can offer everything. So they're very different. And also about the critical thing that we focus a lot in our research is patients' treatment wishes, as in, like, a lot of this research is done without patient say. So we want to empower women's voices to inform what research is happening, what are their treatment priorities, and how can we get there. And I think having this cooperative approach is very important to improve service provision and improve the impact of this research and these treatments on women's health in general.
Yeah, I agree. And just so that we also know what the side effects are of a lot of these treatments. It's so important, because it's great that we have all of these treatments, but we need to know what the side effects are. I'm one of those people that's like, okay, we're going to take this, but what's going to happen after I take it? Because I'm a believer in, okay, it's treating one issue, but is it creating another issue? Hence is why I try and remain as holistic as I can. So I will always try and work out and eat better, cut down on the alcohol, like all of before actually alternating for drugs, or So I think it's important for the women to be involved, so we know what the side effects are.
Exactly.
Would you agree?
100%. And what are the priorities? And you make a very good point, because a lot of women go on like hormonal treatments, and it's underappreciated that hormonal treatment can put you in lower mood, can cause some minor depression if you're on them for a very long time. But this is often dismissed as, it's an okay side effect. So, but no, you have to inform the patient that these can happen. You might gain some weight, for example. That happens if you're on the progesterone-only pill for a long time. So it's having these discussions. It's important so that the patient is making an informed decision about what's the best treatment, and also adopting an escalation policies. And like, you can start with this treatment. If it worked for you, perfect. If not, you can escalate to this. So the patient does not feel, oh, well, I tried this, there's nothing else I can do, I just bear with it. That's not helpful. So they always know that there's a plan to help them reach the state of health they'd like to be.
So what are the correlations, since this is a hormonal issue, which I've just learned today, and I'm like, what? Mind blowing. What are the correlations or the likability of somebody who suffers from fibroids to suffer from loads of other women's health related issues, such as PMDD, PCOS?
Sure. We don't have clear understanding of this. And so you might postulate that someone can have fibroids, will have heavier periods, more painful periods, for example, but whether their hormones will be in out of balance, which lead to, say, polycystic ovaries or PMDD or PMS, we don't have a great understanding of this yet, unfortunately.
Okay, so more research needs to be done.
100%.
Because for one, as I said to you, the research that I'm hoping to do is the correlation between premenstrual dysphoric dysfunction, which is something that I suffer from, and neurodiversity. What are the links there? And now you've mentioned that these conditions are hormonal. I'm like, that makes so much sense.
And look, we all controlled by our hormones, and our hormones are very potent, chemicals that control so many aspects of our health and our, well-being in general. But it's often adopting this siloed thinking when you're thinking about one condition without thinking of what else can be transpiring. And this is a common thing where we see, for example, women with polycystic ovary syndrome, because they have imbalanced hormones. I'm diverting from the topic today.
Oh no, I love this.
But they have a lot of like mental health issues. They have a lot of body image issue. They have a lot of weight gain issues. It's all because it's all linked to the hormonal problem at heart, which is at the center of this syndrome. So you're very right in making this deduction that hormones are influencing fibroids. They might be influencing something else, but we just don't have the type of research that has linked them together, unfortunately.
The research, the data is not available. And then, what advice would you give to someone who has been recently diagnosed with fibroids? What steps do you first take? How do you deal with this condition? How do you maneuver around it on every aspect, the physical aspect, the mental aspect, and even just like, how do you put advice as a professor, a doctor, a surgeon? How do we navigate through this? What do we do? Help!
Look, I think, as I mentioned, it all starts with getting the right diagnosis. If you have had a fibroid, often it gets mentioned. If you had an ultrasound in the community, ultrasound is a very good test because it's not invasive and it's safe, but it's very operator dependent. So if you get scanned by someone who's a general sonographer, it's different. If you get scanned by an experienced gynecologist who has advanced skills, because they will describe the fibroids differently. So first step is getting the right diagnosis. What's the size of these fibroids? Where are they in the womb? What is their number? And then from there, speaking to the right health professional that can give you advice. There's often a barrier there. So, for example, if you had only like 2 fibroids and you say, I'm fine, I don't have any symptoms,
Yeah.
the GP will decline to refer you onward to a
Yeah.
gynecologist.
That's been my issue. Yeah.
And so, we have to bypass that. I'm a strong believer that women should have access to gynecologists or women's healthcare professionals without this barrier of primary care if they need to, but the best place for them to receive concurrent care is in primary care in the community. But if you look into other models, say in Europe across the channel, pediatrics and gynecology, they're straight referral without the need to go to a GP. But that's a wider debate that we can have about the structure of the NHS. But beyond that is speaking with the right healthcare professional that gives you advice. And then from there, I think there's a lot to do about understanding your own symptoms, because you might be dismissing things. So, keeping a diary. When I was on my period, it was heavy. I felt bad. I felt low. I felt irritable. These are my other symptoms that I'm suffering from. Because when you go to your doctor with this diary, with this organized symptomology, it makes the consultation so much easier and so much more informative. And we're we are guilty of that. Like we had an event the other day for patient-facing events on heavy periods, and we were asking all the women, like, when you see the doctor, how do they quantify the heaviness of your periods? And the answer was like, they ask you, is it heavy or not? But the reality is that heaviness of period is not a dichotomous entity. It's like when your periods are heavy, you're often in pain, you're often in low mood, you often have intimacy issues, you feel ashamed, you have impact onto your general health. And so all these other symptoms, they get all summed up into a dichotomous question, which is, are your periods heavy or not? It's an oversimplification, but I think it's just the culture of the health system that needs to change, and we need the right assessment tools. So that's why I'm saying, keeping a diary of your symptoms and going to your doctor with say, these are my symptoms for the last 3 months, and this is the scan. Help me to understand them and find a causality and a treatment. And I think that will make the consultation far more informative, particularly if you've been waiting for this NHS consultation for unfortunately, I think in my clinic, the waiting time is now 8 months, which is sad.
Yeah, it's like a lottery.
Yeah. So hopefully this will change, and we're very hopeful that there's more funding in the NHS. And then from there, I really believe in the role. A lot of people don't subscribe to this, but I believe in the role of peer support. So just go online and find not online, it might be in your own social group or group of friends at uni or at work.
I agree.
Who suffer from the same thing, and speak with them, because you often learn a lot of what did they do, what did they explore, what treatments they found, or which doctor they found helpful, and so on. I think at least that's a roadmap to gain control of your health and gain control of the situation.
Just to reinforce what the professors just said. So that was actually my journey. So it took forever to get diagnosed with premenstrual dysphoric dysfunction. I just said, right, this is getting out of hand. And every month, 10 days before my periods start, I'm falling apart. So I started to keep a diary, and I started to write all of the symptoms that I was having, and this was happening. I noticed it was a pattern. So 10 days before my period, every single month, this will happen. So then I just went on YouTube, and I was like researching things. And then I think I saw a girl talking about premenstrual dysphoric dysfunction, and her symptoms were the exact same as mine. And I was like, what on earth is this? And then I just went into research overdrive, and I was like, okay, I have this thing. I went back to my GP, and he was again trying to be dismissive, and I said, listen, no, you're going to listen to me. I think I have this condition, and you need to send me to a specialist. And that's eventually when I got sent to a gynecologist, which took about a year, by the way, to see. And within, I kid you not, 10 minutes of the gynecologist having a conversation with me, he went, oh, well, you're just suffering from PMDD. You're not going.
And the treatment is
and I just remember I sat there and I cried for about 10 minutes. He came in, he gave me a hug. He goes, "It's okay. I get loads of women like you every day. He says, it's going to be fine. You're going to be okay." And I was like, it has taken such a long time. So as the doctor said, the importance of tracking what's going on with your body and writing it all down, keeping a diary, and actually going back to your doctor and saying, no, you have to listen to me because I've been tracking this for a year or two, and these are my symptoms. I need to go and see a specialist. So just to reinforce what you're saying, through my own personal experience, that's definitely how it went. Okay, so just in closing, where do we find you? Firstly, if our listeners are out there going, oh my God, I need to speak to this doctor. Where do we find you? What's the best way to reach out to you? Where do we find your work so we can read?
Sure.
Yeah.
Thank you. It's really humbling to be on this podcast today, and I really appreciate all the hard work you do. I have on my website, I have all my contacts on my personal website. You just type it in Google, it will pop out. My research is on the both UCL and Anglia Ruskin University web pages, and you'll find it very easily. And as I mentioned, we have a YouTube channel on menopause called Menopause Symposium. If anyone is interested in menopause, we often do an evidence-based take on all different health issues related to the menopause. And we do quite a lot of patient-facing advocacy events for different women's health topic that we do research on. And we're very, very keen to have women's voices inform our research, because ultimately we're a strong believer that this research has to impact and improve their health and improve the whole health. And in our work, I'm a strong advocate of the vision that women's health is a proxy for a healthy society, because that's what gives you a healthy family. And so investing in it is a recipe for improving the whole health of society. So something we're very passionate about, and we hope a lot of the listeners will contribute into our work.
That's amazing. Guys, did you hear that? A proxy for society. Wow, I'm going to get that written down somewhere and frame it. That's amazing. Doc, thank you so much for coming over and giving us all of this insight. I have learned so much today, as I'm sure all the listeners will. And I cannot wait to have you back.
Pleasure.
To talk about more important subjects on women's health. Thank you. And hopefully we'll see you soon.
Thank you very much. Have a lovely day.
Thank you.
Cheers.